Well, this is definitely a big topic. It is a topic that's become a major passion of mine over the last year or so, 2 years. Today I'm really mostly going to try and focus on the CT, on the imaging, on the things that we're finding. I'm going to talk a little bit about some sort of gee whiz things that we're finding. I'm not going to go a huge amount into specifics of what diagnostics, what treatment, things like that. If people have questions, please do raise your hand, speak up, happy to chat about them. But today I wanted to focus mostly on what is it that we're getting out of the CT, our machine, and why is it that that information is important for advancing what it is we're doing. And really the starting point is going to be this right here. 20 years ago, if you were doing a myelogram, it was all radiographic, you weren't going to have a CT at all. Probably in the last 10 years or so, having CTs where we can actually get the horse's neck in and get a full CT myelogram has been a huge benefit. We're finding all sorts of things. We start talking about axial compression as opposed to just dorsal and ventral compression of the spinal cord. It's become certainly a big frontier in terms of, well, if you don't have a CT myelogram now, you don't have enough information just with the radiographic myelogram. We now are starting to, over the past 2 years, we've been developing sort of this technique now, which I talk about as sort of the dynamic myelogram or the dynamic neck CT, where we're actually able to get full flexion and full extension and neutral CT myelograms going on, and just CTs of the neck in general. Correct me if I'm wrong, Rodney, from talking to Natasha, I know there are 2 places in the country, us being one of them, that are doing these routinely. There are a bunch of places that have this set up now, but are still not necessarily doing this routinely with their myelograms. It definitely takes a few more people. It's a little bit more labor intensive. Our room is actually physically set up. We've got anchors on the walls in the back and the side, in the back over here, to try and put ropes on the horse to get them into the right position to hold them there so we can get this information. And one of the things that you will see as we go through this talk that is a running theme, if you take nothing away from this, take this away, is that there is pathology that we are finding that we are missing if you don't have the dynamic CT. You know, it's been absolutely phenomenal just seeing these things. So just to give, actually what I would like to at least have mentioned back here, just to give you an idea, this guy here is a 1,400 pound warm blood. This is a 1,350 warm blood, just to give you a sense of the size of horse we're able to get that much in one go. The other nice thing is, frankly, about RCT, being a fan beam as opposed to a cone beam CT. There are all sorts of things we can get into, but the nice thing is you've got all of these slices all the way through, right? You've got a whole lot of detail all the way through here. You don't have angulation artifacts that you're worrying about. It is a slice by slice modality, so you get a high degree of detail all the way back, which is nice. And then in this case, this is actually a standing CT. Decent sized warm blood mare, 15-year-old warm blood mare on this one, but getting all the way back to, this is the 5-6 joint right here. Smaller horses, thoroughbreds without much of a long neck, C4 is probably about as far caudal as you're going to get, but we're definitely getting pretty far back in a lot of these standing CTs, which has been pretty awesome for a number of things, including what I'm going to start with, just a few sort of gee whiz cases that are interesting to see. So I get this set of text message images, right? Horse acutely swollen inside of its neck, not terrible, kind of painful to palpation, took neck radiographs. Definitely seeing these weird lines, assuming it's got to be a fracture there. Sure, that makes sense. The question really is, how bad is it? What does it actually look like? So this horse came in, she's an 8-year-old warm blood mare, supposed to be a jumper. Came in, we did a standing CT on her, didn't have to worry about anesthesia, went all the way back to C4. You can see sort of at the very edge of the image here, and I don't have a full video of the subsequent ones, but it's interesting how much this horse, once she was no longer painful from this, we could actually get further back to C5, and just the amount that you have to stretch them out to try and get that actually plays a significant role. We had another horse, a similar one, so this is a 3-year-old thoroughbred that came in, same thing, acutely swollen on its neck, right? As well? Or?
He was a steeplechase.
That's right.
Steeplechase,
At all.
fell at the jump, and came in probably about 3 or 4 days after. Yeah.
Both of these are acute. Yeah, this one was also about 3-4 days after the initial insult. This is where the fracture goes. It's nice to be able to, we knew there was a fracture there beforehand, that's fair. The big things that we were trying to look at were, does it look like there's anything impeding into the cord anywhere here? Are there any articular pieces here, which there are, and how is that going to affect our prognosis going forward? These are 5 months out, and conservative management, just time, SARS, that's all it was. And these guys have healed up really nicely in just 5 months of time. Particularly down here, just sort of how much bone remodeling there is. It's been interesting seeing some of these. You get a fair amount of periosteal reaction that does come around outside, and somehow you still don't seem to have a huge amount of periosteal reaction on the inside of the canal, which has been one of the things, particularly with the follow-ups, we've been most interested in, especially for horses needing to go back to racing and horses needing to go back to jumping again. These are the same 2 cases, again, racehorse and the warm blood here. Just to give you an idea as well with the machine that we have, these are not CT monograms, these are not contrast, but again, when you're talking about neck fractures and you're talking about wanting to get somebody back on that horse and go out and run fast and do jumps, do we feel like there's any concern for spinal cord, for compression? Is there anything, soft tissue or otherwise, that may be impeding on that? And we're fortunate the machine that we have has quite a good soft tissue algorithm, so it's not a myelogram, but you can, as you go through, see where the dura is. It's not the cord, but it is at least the dura here. As you go by where the fracture is, you can see that you seem to have a fairly nice, big, round dura. There isn't anything impeding on it. So we're happy sending both of those back. This guy, the racehorse, is 5-year-old year. I think he made 135,000, averaging 20,000 winnings per race. She's back to jumping again now.
Yeah, the steeplechaser went on to win a Grade 1 race after that. Yeah.
Okay, moving on a little bit on my GWIZ cases before I get to the things I'm really interested in. Ribs. Ribs are an interesting area. We found a bunch of rib lesions as we've been doing these monograms, and I'll be totally honest with you, don't know what most of them mean. There's not a huge amount of literature out there. There are some people out there in the world that are starting to get more interested in the ribs in particular. There's a chap over in Belgium, who's starting to try and compile a whole bunch of cases to try and look at clinical relevance of some of these. Again, the reason this is sort of just interesting, incidental findings, was a horse came in for a myelogram, and this is a 17 to 1,600 pound warm blood, just to sort of give you a sense of what we're getting in the machine and what the information is we're getting back out of it. In this case, so synostosis of the first and second rib there, completely incidental finding in this case, as it was completely the opposite side of the horse from where all the pathology was, where the clinical signs were. There is one paper on these that I was able to find out there, which is incredibly helpful. It tells you that these can be either completely incidental and irrelevant, or completely career-ending and significant. And without really much explanation other than, if you have it and it is associated with lameness and you can't find anything else, there's not really anything you can do about it, so it's probably relevant. But if it doesn't seem to be relevant, then it's probably not relevant. Great. So in this case, again, we had, I'm trying to remember, I believe this was the left side of all the pathology, or the lameness and the other things were all on the right-hand side, of course. So incidental finding in this case, but just interesting to see. And we've been trying to make sure that we get back and try and get these sort of first, second, and third ribs with most of our myograms, most of our necks, just to try and get some more information out of them. So two more rib cases just to illustrate a little bit of the difference between what may or may not be clinically relevant. So again, CT myelogram, this does happen to be on the clinically relevant side, and this horse will come back later on. I think I put this horse in here. I did do surgery on this horse, not for the rib. So small fragments right here at the rib head. So C7, T1, where the rib head comes in, rib head coming up right here, T1. You can see there's actually a fair amount of pathology. Here's our fragment right in there. The nice thing in this case is even though there was a fair amount of pathology through the articulation, and it'll cycle back through here in a second. So you've got some cyst-like lesions there. It makes it look like there is some active inflammation there. But ultimately, the fragment's not that large, and it's quite a ways away from the spinal canal. I can see that in ultrasound. I can get a needle down to it on ultrasound. And this horse did actually have foraminal stenosis. Took it to surgery for that, which seems more likely relevant, and I can very easily do something about that. I don't know yet about this. I'm interested in the possibility of trying, although in this case, I think it was much less likely to be relevant to the horse's clinical signs. If it seems to be coming up again, I'm more likely to start by trying to inject it, mostly because the pathology is further away and it's more extra-articular. As opposed to this case, so similar, this is a first rib. This horse was presenting predominantly for refusing to go over jumps, or was landing weird and not taking his jumps well, or going to the left. It was not specifically a neurologic disease. It was really more performance-based. But, you know, Rodney was able to find a little bit of neurologic disease. Great, fantastic. do the myelogram. And realistically, this is where the majority of the real findings were. So, again, we're looking at 7T1 in here. Oh, great. Nice of me to put my pointer in there. This fragment over here is actually right up against the bone. There is actually even this small piece right here out of the body of the vertebra. And more concerning is that that is truly right next to the disc right here. And what we actually have going on is this mineralization is going to come in over here, mineralization of the disc right there, and predominantly on this side. As you see up here, we've got a nice normal disc space here, not so nice normal disc space here. You can see we're sort of right on a similar plane here. We're not too far around one side versus the other, but starting to lose disc space in both of those. So you're not actually getting compression of the cord here. The horse doesn't have significant neurologic disease associated with it, but it's having pathology or it's having clinical signs that are preventing it from doing its job. And the only thing that we were able to come up with on the myelogram was this finding. Again, I can ultrasound this, and we did. I ultrasounded it, ultrasound guided, injected this with steroids, and the horse was better for a week or two, and then just didn't quite improve after that. And this one is going to be it's going to be a bit of a challenge to decide what to do, because with the disc disease there, it makes you think you want to fuse it, but a horse that doesn't have neurologic disease, especially going to fuse a 7T1, you don't love the idea. There's no cord compression there, but I don't necessarily have another great explanation. Because of the anatomy in this location and where the nerve roots are coming out, what I also don't know, just pulled myself a new textbook. It's great. It's degenerative radiculopathy and cervical myelopathy in people, all the different treatments and things like that. And it's incredible the degree of pathology that they are treating people with things. And we are only scratching the surface. And so right now, that's not accessible to me. The nerve comes out predominantly from the backside of the foramen when it exits the spinal cord, so right where that is. We know in people, radiculopathies or nerve root impingement, pain secondary to nerve root impingement can come from mineralization of the discs in a person you would potentially consider doing either a fusion or a partial discectomy or various other things. In a horse, I can't quite get there because that really is where the nerve is coming out. Big nerves, big important nerves that are important for the horse standing again after recovery, and that's really the major issue with this. So although I can see this on ultrasound and I feel comfortable enough sticking a needle down to it, and the horse didn't freak out and the needle went down to it, I can inject it with whatever I want, I guess. I am not yet to a point where I feel like I'm going to be able to go after that cervically. The other one, more superficial, further away from the nerves, if it really becomes an issue, I could stick the endoscope down onto that and potentially do something. I've not done one of those ever before, but it is a theoretic possibility. I would feel more comfortable with the anatomy, at least, in that area. Okay. Moving on a little bit, specifically more to our radiculopathies, myopathies, a whole bunch of different things to look at here. I'm going to start off chatting a little bit about your more classic myopathies, and I'm going to talk again about our machine and why having your dynamic CT becomes so important. So in this case, it's a 14-year-old warm blood gelding, and it's radiographic myelogram. Unless Natasha told you something differently, it didn't actually call anything specifically on the radiographic. So radiographic, normal. So 20 years ago would have been a normal horse. The image up here is this site right here. So this is 4-5 is the affected site here. This is 4-5 in a neutral position. It's just the horse lying there in neutral, running the CT through it. This then is our lesion inflection. So when the horse goes in flexion, you can actually see a more significant lesion there. And as I go through this a few times, you're going to look right here. And what you can start to see is just a little dip actually in the cord. So you've actually got deformation of the spinal cord itself in this location. And again, this is more, for me, this is more a testament to the machine we have and the level of detail that we are getting in these sorts of cases to be able to see that. And most importantly, in a case where you've done your full radiographic myelogram and you've got a CT, you've done your straight CT, you miss this lesion. You don't find this lesion, you have an inconclusive myelogram, whereas in this case we were able to find, there's definitely definitive compression of the cord and actually deformation of the cord at the site. One of the things that we don't know yet, or is not sort of well defined, and we are starting to work on this, is ratios and sizes of things. So in people, there are very defined sizes of cord diameter, of cross-sectional area, and of dural diameter that human neurology surgeons will correlate with clinically relevant disease. On our radiographic myelograms, we have some standards, right, in terms of your percent compression of total dural diameter and your compression of your dorsal contrast column, right? They're justified, or they are correlated with disease. Interestingly, they're correlated with disease, not necessarily disease at that site, but they're correlated. We don't have any of those numbers yet for the CT myelogram. So it is another area where fight's not the right word. I have long discussions with Natasha on the phone sometimes about some of our findings and things that she calls or doesn't call, and the honest answer is we just don't know. There isn't a definitive, this is how big it should be, this is how much circumferential reduction is clinically relevant or not. And one of the things that also then leads to is a bit of a wide differing of opinions of whether or not things are relevant. And at the moment, I don't know who's right. So we are trying our best to gather data and trying to clinically correlate things back and forth. And otherwise, trying to make the best decisions that we can on this. Next, moving on. Okay. Another one, 8-year-old Swedish warm blood. In this case, two major pathologic findings. So here at 4-5 as well, another one that actually has compression of 4-5. Again, this is inflection. They did actually call suspected compression based on the radiographic myelogram there. But the other major finding is going to be this over here. So in this case, this is known pathology, right? You took a set of plain films and you could see that there's pretty significant kyphosis here, just permanent angulation of the spinal column right there, and there's a bunch of bony remodeling. You've lost a disc there, there's clearly new bone remodeling there. On the myelogram though, the interesting thing is that clearly you've got tons of space, right? Even though it's fused in that location, you've got a lot of space. This horse, prior to the myelogram, is doing 3-foot jumping at the moment, and jumping relatively successfully, but just recently started to trip twice, right? So something's going on, and we know that this is going on. We know that there's compression back here at 4-5, and we knew that there's pathology here. The question is, what's going on? We seem to have a whole lot of space there. But again, as we scan through our myelograms, some other things come up. First off, you can see that there's pretty significant foraminal stenosis bilaterally, but more significantly over here. But as we go through this area, there is actually change to the cord shape right in there, and it gets smaller and narrower in diameter overall. So even though you've got all of this space, this isn't a dynamic compression, you've got change to what the cord looks like. It doesn't look the same here and here as it does right in there, and so now we can actually physically see the cord is changing in size. This is an interesting case for me trying to decide what to do. I've got neurologic disease, fair enough. I've got a site of dynamic compression that I can do a basket on. I can fuse it, that's fine. This is already fused. And on the CT, because we've done flexion and extension, I can tell you that that stays 151 degrees. Whether it's a flexion, whether it's an extension, doesn't matter. That stays 151 degrees. So for all intents and purposes, that's fused. So the question is this change in cord relevant? And again, I don't know. I don't know, and there are essentially, three things to do. One is to say you've got two sites of pathology, retire the horse, move on. They like the horse, it's only 8, I see that right? So I did, this is another area that I'm curious about. I sent this out to a few other people around who are doing these surgeries. Surgeon out in California, surgeon out in France, surgeon in Australia, and got a lot of people suggesting that we could straighten this out. And well, once you try and straighten out the neck, you'll get some straightening of that area. Interesting, they sent me a few cases, none of them have that. The other thing that I find interesting is that none of them do a dynamic CT, nor are the practices doing dynamic CTs, period. So my question mostly is, how do they know that they'll get more? But I don't know. The biggest thing in this case, actually, for me, is that this seems more relevant. The fact that there is change there seems more relevant. These owners are definitely dedicated to the horse. They're interested in doing something. But again, going through the full CT, and I didn't want to put absolutely everything in here and really bog down technical details that probably aren't that interesting to everybody except me. The standard basket is probably not a good option in this case. In order to try and break all this down, I'm probably going to end up with too much of a defect. It's going to be less stable than I'd like it to be, which suggests trying out a different construct. So we happen to, a friend of Dr. Gazdrowski's, surgeon out in Australia, happens to be coming to the States. He does spacer and plate construct that's out there. Should offer a little bit more stability, especially in a situation like this where I'm going to have to physically deconstruct all of that bone remodeling that's down there. One of the things that go through and take a look at it expands an area that is wider than what the basket is. So I'm going to have to deconstruct the backside or the underside of both of these larger than what a basket would be, so I need more stabilization there. So they're interested in coming and trying it out. So we've got 2 sites to do, and they were interested in saying, well, if you're going to do one, get both sites done and see if you can try and straighten this out a little bit. In people, you can get hypoxic damage secondary to bulging of discs or of the posterior longitudinal ligament that gets mineralized or inflamed in this area, and leads to compression of all of the venous blood flow that runs right along the bottom here, and that will lead to segmental hypoxic atrophy of the cord itself, which again throws a whole other curveball into this, which again I just find interesting, but I don't know what the answer is if I do straighten that out, is that damage already done? If it's a hypoxic injury, is it already done? Am I going to help the horse out any? And again, I don't know. I don't actually know. The horse is actively tripping at the moment, so if we can get it straightened and stabilized, we can go back in and retake a CT and see, and actually now compare, has there been any change in diameter of the cord? This is actually be something that we can actually do relatively straightforward. You wouldn't need to do a full dynamic back and forth, but in terms of giving the owner an idea before they get back on it to ride again, you could repeat that and actually take measurements and have something to compare to and see how that's changed. Okay. Moving on to foraminal stenosis. Foraminotomies, this is my sort of new area of interest. These are all cases that have it to one degree or another. There are a few major things that I want to talk about and sort of point out. There's just a splattering of cases, most of which are pretty obvious to see kind of what's going on. I'm going to start off talking about sort of classic foraminal stenosis, right? These are pretty obvious cases. You've got what should be the nerves coming out, the nerve roots coming out of the cord here, and you've clearly got bone-on-bone rubbing at these sites where something's going on. That looks like a nice place for a nerve to go. That does not look like a nice place for a nerve to go. That seems like a pretty no-brainer. It's fairly obvious that there is something going on. The majority of these cases, and just ignore this one kind of, but the majority of these cases are presenting more for behavior problems, they're presenting for non-blockable lameness or limb lameness, they're presenting for changes in how they're moving their neck, not able to get into flexion, not engaging with the bit, changing how they land from jumps, how they take off from jumps, how they land, especially one-sided. They won't land to go to the left, they will to the right. Not usually presenting with a large amount of neurologic disease. It is interesting that some of them will still present with some degree of neurologic disease. Certainly if you look really hard for a lot of them, and most of these guys are big warm blood, you'll find a little bit there. Well, he's good at that, which is great. I've been surprised a little bit by the degree of neurologic disease that some of these horses have or don't have, and don't have the up here. But I would say one of the cases that had probably one of the most significant neurologic disease fell into this category, really didn't have a whole lot of cord compressions, doing really well after surgery. The neurologic disease seems to be improving from that. I don't have a good explanation for why that horse was more neurologic than some of these cases were, but that's just sort of the way it is. With some of these guys, trying to chat a little bit about radiographs and how you interpret and how I've started to change my interpretation of radiographs a little bit, particularly in the caudal neck. You'll notice that all three of these guys, none of them actually have any evidence of ECDM, equine cervical vertebral malformation. They've all got their ventral lamina bilaterally on a C6, which is great. But all of them definitely have, I'm sure everybody probably in this room can sort of recognize, you take a look, it's like, okay, well, looks enlarged, looks enlarged, looks enlarged, great, fair enough. The question is, how do you go from this to this? Obviously the CT. Some of the things that I'm paying a lot more attention, or trying to pay a lot more attention to this ventral aspect. I'm guessing probably, particularly from the back, this radiograph probably shows it the best, where you truly have this line that not only overlaps where the foramen should be, but seems to overlap where the body actually should be. You'll find that these cases will often have what appears to be increased sclerosis, although it may just be superimposition, truly, of more bone in this area, right over the caudal aspect of C6 or the more cranial vertebra. The tricky thing with that really is that you're trying to make an assumption based on an imperfect radiograph, right? And it's been something I've worked with just myself in my positioning and trying to get sort of the perfect lateral radiograph, and knowing that because of beam angulation, right, just because you're perfectly dorsoventrally lined up down here doesn't mean you're perfectly dorsally ventrally lined up here. So I will often take and accept multiple different shots at each site because I'm looking in for different things. Particularly in these, what I really want to try and see is lining up of the dorsal aspect of the joints. If I've got pretty good lining up of the dorsal aspect of the joints, I'll tend to believe this a little bit more. I like it if I can see it in a few different shots would be great. But you'll see like this guy is pretty close to even up here, definitely not even down here. This seems a little bit more even down here, probably just a little bit off up here. This one's a little bit tricky to interpret in terms of where are the two sides of it. But again, these are the referring vet films that correlate with these CTs as well. As we go through, you'll see a few other ones that have similar degrees of foraminal stenosis without that obvious overlap. So it is definitely one that I'm not making a call based on the radiograph. I'm changing the way I'm looking at it, particularly on pre-purchase exams. The way it really drives me crazy is how do you try and interpret this on a pre-purchase exam? Still don't have a good answer for you. I'll keep you posted over the next 5 to 20 years. But again, it's a matter of is the radiograph perfect? Is it lined well enough? And even still then, needing the CT because there just are varying degrees of what you're seeing. Keeping with the theme, the dynamic CT is still changing things as far as the foraminal stenosis goes as well. So again, these are all paired studies. All of these, the flexed view up top, the extended view down below, and you can see on a bunch of these that there's a clear difference one to the other. The other thing that's important is that it's not necessarily always the extended, sometimes it's the flexed. Even all of these are C6, C7, but even though they're all C6, C7, they don't always get worse in extension or don't always get worse in flexion. So this guy in particular is a good example that this is truly the extended, although the neutral CT doesn't look too different than that. So if you go and you do radiographic myelogram, you're not going to see any compression here. You go and you run just your straight CT afterwards, you're not going to see any compression of the cord there, and it's questionable whether or not there's a whole lot of foraminal stenosis. I mean, how much are you going to call that? Do you do something surgically about that? The one thing that I guess for me as I'm reading these more and more, I would start to say, well, I've got more sclerosis down on the vertebral body down here. I've got a little bit more sclerosis in the articular process there. So this will be C6. This will actually be C7 right there. So maybe there's something going on there if I didn't have the flexed view here. The other thing that is interesting is once you get the flexed view in there, now you've suddenly got all this contrast attenuation that's going on there as well. So this horse did present with a little bit more in terms of neurologic disease as well, and as you actually scan through that, there's a slight shift in how a cord looks at that location as well. So if I didn't have the extended, or the flexed view in this case, only had the extended, I might not have done it for, again, you would have had an inconclusive myelogram, and wouldn't know sort of what best to do. So the new sexy thing is doing foraminotomy surgeries. That's sort of where we're going with this. This is all endoscopic surgery. This is minimally invasive surgery to try and physically do something about the bone-on-bone rubbing here, enlarge the area. We first started to be done in horses in 2020. Came to the States last year. We've been doing it here now since December. So again, all of these cases, this is your pre-op myelogram and this is your post-op CT. So For right now, I'm taking all of them directly into the CT after surgery and running a post-op to take a look and see what we can find there. And again, in all of these cases, the goal is you're going in and physically just debriding some of the bone here, remove it, so now you have a much bigger opening. You don't have that stenosis there, trying to find the right angle. These are your sort of classic foraminal stenosis cases. I've got a video at the end here. I don't want to get huge amounts into the specifics of the surgery. It's a very cool surgery. I really enjoy doing it. But some other uses for it, or other ways to come back. These are two cases there really isn't specifically foraminal stenosis per se in either of them, but what you do have is specifically more significant axial remodeling of the joints that is leading to physical impingement, contrast attenuation, cord change, and potential neurologic disease, axial compression neurologic disease associated with that. Again, these are ones that you're not going to see on the radiographic myelogram. Once you've got the CT, you can actually see where it's coming from. This case in particular, I'll touch on for some other reasons, but these are places then that as you're coming in here with the endoscope and the instruments to remove the bone here, you can carry it on as far as you want, essentially, to try and get cases, to get other things out of them. So again, running along the theme here, the dynamic CT makes a huge difference, right? So this guy here, flexion versus extension. Again, in the extended views, you're not going to call any compression of the cord here. You're not going to call contrast attenuation. And frankly, you're not really going to call foraminal stenosis there either. This horse did also have some circumferential compression at another site, but this, for me, meant it took this case from a two-site basket on a horse whose goal was to be a Grand Prix dressage horse, and made it into a one-site foramen, a one-site basket, which at least increased his chances of potentially being able to get there, or at least that was the goal anyway. Again, whether you see the compression and flexion versus extension, there's no set way. Again, in flexion here, you've actually opened up the space more, and in extension, you've actually got quite a bit. I mean, I would say of all of the ones, you get sort of the most shape change in the cord. Interestingly, this guy, not terribly neurologic, and that really wasn't his original complaint, was not neurologic disease, which again then begs the question, do you really want to go and fuse this? The other thing that's important or to think about when you're talking about these surgeries, when you're doing a fusion surgery, you are generally fusing them in extension. That's the way you do it. You put them in the back, on dorsal, neck extended, that's the way you're going to be. And in this case, this would absolutely be a terrible case for trying to fuse this, because trying to fuse this in this place fuses it in such a way that just puts more pressure on the cord. So going through the first place again, went to the foraminotomy. Yes, I didn't need a huge amount of opening. He's got space for the nerve there, but what I'm trying to get is that bit of bone right there. It's using the equipment to get to this bit of bone. Yes, I can see there's a little bit over here, but it's actually adaxial to where the column is versus this side where it's actually physically going in and impinging on the cord there. So being able to actually go and take the scope all the way out, remove that spike of bone that's right there, and actually have it up and have a nice smoother area. This guy certainly initially came out of surgery more neurologic than when he went in, and 3 weeks later he was less neurologic than when he went in. So definitely a pretty significant improvement. And again, this is here doing some somewhat intensive, although easy for owners to do at home, PT, which is mostly hand walking and doing cavalettes and neck stretches and going out on hand walks and doing circles. Taking a huge amount of time. So again, this chappie, just going through, this is again the pre and post-op CT. So this is what I need to get. This is where the majority of the compression is coming from. You can see it really starts with a huge amount of soft tissue compression. So there's some good contrast arthrograms out there, CT arthrograms that show just how extensive the joint space is. On all these, and the cranial pouch in particular of the joint is more extensive, and that's really where a lot of that attenuation was coming from. But again, it's using that, using the equipment, using the endoscope and the burrs to actually get in there and remove the spiked bone that was physically causing the impingement. Am I losing anybody yet? I can talk about this for a while, but just a few last things to sort of go over. These are some non-myelogram things. Am I losing people? I can shut up immediately. So this horse was actually, Dr. Thurston's came in predominantly for having trouble, believe it or not, trouble rounding into the pole. But again, sort of neck changes, stiffness, not actually engaging into the bit, more performance, not neurologic. So came in, Dr. Thurston did the evaluation, and we're like, okay, well, as a starting point, we've got radiographs. We knew that there was enlargement here, and sort of overriding of the process. This is another example where it's a nice straight radiograph. You've lined up your foramen over here. It seems to be fairly straight up and down. Yes, it definitely impedes on the foramen there, but I wouldn't have thought that degree of impediment to actually have bone-on-bone rubbing there at that site. So it's pretty significant 1-2 changes in here. Interestingly, this is down at 4-5 in this horse, where it already has some evidence of more mild, but some stenosis there. And on his radiographs further down where we didn't get, he's definitely got some more significant evidence, and based on his full clinical signs, the ultimate recommendation and the plan is the horse is going to come back to actually get the full, hopefully going to come back and get the full neck CT, because the question then is this relevant? Is the most relevant thing that he kind of flex into his pole as much as they would like, or is the more relevant thing that he is starting to buck under saddle and maybe more associated with nerve compression down here? No, this one's not having lameness issues. Whatever one was. This one, interestingly, does also actually have ECVM, so it's got transposition of the ventral process over here. You've lost it over here on this side. You can see the one side, this is where the other side is, and here's where it's transposed over there. So really interesting to be able to get this information standing. Obviously, you don't have the myelogram, but that's fine. I wasn't looking for neurologic disease. The major thing that we missed is when we got full radiographs, you can see there's probably stuff lower down. This suggested that he clearly seems to have a predisposition. It's worthwhile looking at this if they're interested in going further with it. Another quick case, this is hopefully the last case, and I'll have a quick video of just what the foraminotomy surgery looks like, just because I like it. Again, a horse came in for performance issues. Dr. Gazarowski saw this one, predominantly left-sided issues. It had this on-again, off-again, predominantly left front lameness. They were never able to blocked it all the way up the leg several times. They were to the point of next thing, okay, well, let's try injecting the neck, and the owners were like, well, let's do some more diagnostics before we just inject the neck. Great, fair enough. Came in, had bone scan, definitely had pretty significant uptake over here. Interestingly, the left side, I should have put the right side in there, and I didn't, but the left side more significant than the right side, although there is uptake on both sides. Took radiographs. This is another one where, yeah, I've definitely got some overlap there. When I start looking up here, I'm feeling more like it's not quite lined up on the dorsal, so how much do I interpret that? I don't know, I'm probably not going to over-interpret it. But I've clearly got some pathology going on there. There's definitely enlargement there. This horse we ended up doing a full neck CT on. And initially, this is actually the right side of the neck over here. This is the left side. Initial going through, this is kind of underwhelming. It's having this lameness that can't be blocked. It's on the left side, it's the more significant side, and yet I seem to have more space over here than I do on the right. That seems a little bit more underwhelming. As we continue to go through, though, this is another case where what we actually see is we've got some mineralization here in the disc, and that is on the left side, and that is right smack dab in the middle of the foramen where the nerve is wanting to come out right there. Again, it's not so much likely impinging on the nerve, but the fact that you've got mineralization there suggests a localized area of inflammation. It is asymmetric, it is predominantly on the left side where the majority of the clinical signs are coming from. And again, we know from people that that is enough to give you a radiculopathy, pain associated with the nerve roots. So now I've got something a little bit more to go on. The problem again is, I probably can't get to that, but I do know that that's a little bit smaller than normal. There is some increased pathology, increased sclerosis down there, so although not classic and bone-on-bone rubbing there, if I were to open that up and create some more space up here, does that allow more space for the nerve to come out and this inflammation goes away a little bit? Maybe, maybe not. The horse has a few other things going on, which are just, again, sort of side notes, but interesting to see and things we're seeing without the myelogram. But at the back here, again, this is still C6, C6, C7, same location back here, but there's actually some remodeling right back here where the posterior longitudinal ligament would come through and attach as it's making its way along. And if you look at where the dura is there's a small indentation there. Again, horse is not having neurologic disease, but would you start to see something more there? And if you put the horse into flexion and extension with a myelogram, would you start to see something there? And would it change your thoughts about how you would treat the horse? Just interesting. This probably doesn't show up quite as well, but this is now T1, T2. And you've actually got some bulging of the discs, some decreased disc space, and some mineralization of the disc back here as well. So again, you start looking on a sagittal view, and it makes you think that maybe there's more going on. Again, the horse is not neurologic, but in this case, this is the case that the major question for us at this point is, can we do something to help the horse, and what is it? There are a number of things here. I don't know if all of them are to blame or not to blame. I'm not doing anything about that. I can't reach that side anyway, so it sort of doesn't matter. But I can do something about this space, whether it is fusing that space or whether it is trying to do a phragmotomy. So in this case, what we elected to do is actually a nerve root injection of only this space and only on the left-hand side to try and see, is there enough change in the clinical signs to suggest that, yeah, if you get rid of inflammation specifically right there, that actually has an ongoing difference to the horse. So it seems that the people who are doing a lot of these procedures are finding that to be a diagnostic positive. So positive response to nerve root injections at a known site of foraminal stenosis is usually indicative or suggests enough that that is playing a clinically significant role in whatever the lameness is. Unfortunately, the flip side of that is that if you don't have that response, it does not mean that you are not having a clinically relevant problem at that site. Which throws a whole other wrench in the work. Another diagnostic that I have started playing around with a little bit. Some people have been doing some caudal epidurals, steroid epidurals for horses with hind end issues. I've now started attempting a few ultrasound-guided C1, C2 epidural injections, not subarachnoid, not actually getting a tap, not getting fluid, but in this epidural space. Here's a 1999 paper on one horse that I did under anesthesia, and it took a horse with suspected radiculopathy and made him comfortable for, I think they were up to 14 or 15 months by the time the paper was written, and the horse was still comfortable. So I actually have this. So yeah, this horse. This is the same horse, actually, these two sites. Having some performance issues. They really wanted to do some prehab with the horse ideally. One of the major issues, the horse was starting to have issues, but had come back from Europe, it was underdeveloped, his muscling was bad, they weren't very happy with it, they needed to put conditioning on, blah, 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 lots of things. But was also having these signs that seemed to be relevant to mild neurologic disease, so we did the myelogram. We found this, clearly a problem, worthwhile doing a phragmotomy on. They wanted to try and get some prehab done with it. They also really wanted to try and see if they could just get through Florida, because it was one of the only horses they could take to Florida in the summer of their 10 horses in air. But so wanted to try and see if they could get through, right, a little bit more, which is fair enough. It was a young horse. They had previously, the horse had always responded to injections in the neck. They were doing facet injections, but they were to the point now where they're doing facet injections every 2 to 3 months just to keep them comfortable enough to be able to do the rehab they wanted. So knowing that the plan was this spring to do the procedure, we ended up doing an epidural, and certainly as of 3 months out, the horse was still performing nicely, was putting on muscle, and was actually doing his prehab appropriately. So hopefully, just reached out to her today, and I've got a call with her tomorrow to try and see if the horse is doing well, if they're ready to consider doing surgery. That's mostly what I've got on the imaging. Some really cool things. The more we're going through it, the more I'm learning and finding things on the CT. It's incredible, and the more I'm not knowing what the hell to do with it, but trying to figure things out a little bit. We're very fortunate. The company that Revo Spine that gives us all or we get the endoscopic equipment for the foraminotomies are highly motivated in trying to put some research out and trying to get this procedure further developed in horses. They have been instrumental. They've actually put together, we've got a WhatsApp group of every place in the world, that actually has one of these. There are about 12 of them at the moment, 12 or 13, and about as many surgeons who are actually doing the procedure at the moment. So we've got a WhatsApp group, and they do a monthly conference call where we all just try and talk about these cases and talk about, okay, this is what I've done, this is what I'm trying, this is how I'm trying to use this. Has anybody found anything different? What do you guys recommend on this case or that case? It's been great. So hopefully we can watch this space. Dr. Slagmaker out in Munich, he and his residents / PhD students have done about 300 of these now over the past 3 years, and in the next year or so have hopefully some good papers coming down the pipeline on their results. Generally, just to give you sort of an idea, it's worthwhile mentioning so far, knock on wood, recoveries from anesthesia have all been excellent from all of these. So far, I have not had any issues. Globally, yes, 400 or 500 done, but no higher incidence of post-operative morbidities really than most other elective procedures. Really haven't been many things. Case selection, I think, is key for a lot of those things. Generally, for the rehab plan that I give to owners, should take them from initial post-op period of only a week's worth of pure stall rest to a week of stall rest and hand walking, all the way up to walk, trot, canter under saddle, introducing some ground pull, some cross rails, some low-level jumping cross rails in about 3 months. That's the goal, is to be able to get to that point. We find a lot of cases have multiple sites that may need a foraminotomy. Again, Dr. Slagmaker's found, with his numbers at least, it's about 50-50 as to whether or not you end up having to do multiple sites for the procedure. So in about 50% of the cases, even though you have multiple sites that would warrant a foraminotomy, they do one site, and that seems to resolve the clinical signs, or at least resolve them enough that the owners are happy, the horse is happy and comfortable and back into training, and they're happy not doing the second procedure. So depending on what the clinical signs are, we can really only do one side at a time because of the duration of surgery, because of the laterality and how it's all done. If I've got a case that is very clearly bilateral 6-7, for example, it's got signs on both sides, it's got the stenosis there, we'll schedule them 2 weeks apart. You do one, 2 weeks, do the other one. For most of the others, we'll talk about get through the first 2 to 3 months worth of rehab, and you'll have an idea. You'll either have your horse back, you'll be happy with it, it'll be moving forward in a positive direction, in which case carry on, we can always do the other side. Or already, yeah, it's gone well, we're just not, there's still more there, it's not quite good, so let's come back in and do the other side. And then just to give you sort of a quick rundown of the surgery itself, this is just a piece together, it's going to jump around a whole lot. Just to give you an idea, this is 10 millimeters from side to side, here to here. This is actually a beveled cannula, you'll see as we go along here. So right now I'm right up against the bone at the very ventral aspect of the articular process, where all the muscles attach down here. You're just starting to see a little bit of bone right there in the background. It's a radio frequency probe going in, cauterizing the tissue a little bit. Pressure rungers coming in, starting to remove some of the tissue, trying to make space. You need to clear away all the soft tissues so you can get access to the bone and actually know where you're actually working things. So again, this is right down to the bone there. Get just a little bit further along now. I've sort of cleaned out more space. You can see as I move back and forth here a little bit, I've cleaned off a little bit more of the bone. So again, with my beveled cannula here, do my probe in, I'm going to rotate things. I've cleaned off where I need to work. Now I need to protect all the soft tissues underneath. So in this case, you've got caudal over here, you've got cranial over here. So as we go this direction is truly where the nerve root is coming out, probably just back here a little bit. Up here is obviously the front part. So trying to establish just a little bit of a plane down below. So this really is the very bottom. You've got ligaments where the muscles are attaching there, just slowly cutting those down, try and get myself. I just want to be able to just see the underside of the process. So here we are, this is just onto the underside of the process here. And now we're getting our burr in here. Again, it's just a protected burr, trying to make sure I'm not doing damage to things lower down there. Snow globes starting to drill the bone away here, just making sort of slow and methodical cuts just to slowly work your way through the bone. I tried to get a full procedure start to finish on this, and my video stopped midway through, so this doesn't go quite all the way to the end, but you'll get the point. So starting to see, okay, here's starting to get my defect in the bone there, great. As I go a little bit further along, this is getting right to the very back. This is actually some perineural fat right here, so the nerve root is coming right the other side of my cannula. This is the very bottom aspect of the joint here. As I'm moving more cranial, this is now actually all joint capsule, and don't quite get into, I didn't quite get far enough in with the video to actually see articular cartilage. You're used to doing arthroscopic surgery, seeing cartilage from the top and scraping down to it. It's very weird seeing cartilage from the back first, as opposed to the articular surface. It just looks a little bit different, but so as you get here, just trying to slowly separate the tissues a little bit. Right there is actually going in underneath into the frame and into the epidural space right back there. So in this case, further here, go down and sort of break the soft tissue, trying to make sure that I am absolutely certain as we go along. This is all joint capsule, not nerve tissue or anything like that. And extending our way down and opening things up. I've got a few pictures, not on here, but of the dura and things like that, intraoperatively, which were always a little bit of a pucker moment. But they just look terrible on the screen, so they look better in real life. But that's what I got. Again, big thank you to all the technicians, Joyce, Britt, Claudia, and Hannah, for everything that they've done to help make this run. And
huge team, OR techs, anesthesia techs, it's interns, it's a huge production to get, especially the myographs done, so we have a great team. You guys have any questions about that?
Somebody's got to ask questions.
So well explained. Not rambling at all.
And there will be questions that you guys have as you're starting to see new cases in the field, consultations, whatever. You pretty much all have all of our cell phones. You're welcome to use them anytime. So as issues come up, text a question, send a question. As you can tell, we're all pretty enthusiastic about talking about the different parts of it. So happy to take the call if you don't want to ask it here.
Questions. What would you say difference between MR and CT of the neck? Just from a human standpoint, all of us have bad backs and everything.
Well, I would say, in people, your gold standard is going to be an MRI. You're going to see a lot more of the soft tissue detail. Most places are probably, I have to imagine, certainly most of the papers are all high field MRIs of people as well. It is interesting, again, the cord diameters and dural diameters are all pretty standardized in people, and for flexion and extension, that's usual. So there are other things that you get out of the MRI. You see localized inflammation, you can see some changes, some more specific changes in the cord and the vascularity as well that you don't see here. There's a huge textbook. We've got a picture with like all the different possible pathologies that you end up seeing in people, and it's a massive list. But basically, we're talking about foraminal stenosis with bone and compression of the cord, like dynamic compression of the cord, and that's it, as opposed to all the other things. So you see a lot more soft tissue disease. Some of it comes from just the way that the equine cervical spine is put together. The disc in particular is very different in the equine spine than it is in people, and therefore some of the ligamentous attachments, though they're the same, probably aren't as. The disc takes a lot more of the force, and the disc is a lot more responsible for the stability of the neck than it is in people or dogs or cats. You can actually disarticulate the spine, remove all of the joint capsule, remove all of the ligaments except for within the spinal canal itself, and just leave the disc, and you'll still only have, it's about 30% increased mobility. 70% of it still is intact just from having a disc holding it in place, having cut all the other things which you wouldn't have in people or dogs or cats. So MRI would be great. Not really feasible at the moment.
Yeah, the
At
practicality,
all.
I mean, the amount of hours, that if you could find one big enough and detailed enough to do an entire
Yeah.
equine neck, the amount of time that you would need to see the entire thing would be hours and hours and hours.
And I think I've thought about this a little bit because I've been curious. If you took a standing MR machine and you just remounted it vertically, so you could just put a horse's neck into it, which you see it. The problem with a low field is your spatial resolution. You sacrifice spatial resolution, which in this case, the spatial resolution is what I need. It's those small details that are leading to how much foraminal stenosis, the small amounts of bone remodeling. There are a few cases that I didn't go into here where there are, again, a small bits of mineral, but I'm making decisions based on remodeling to the joints that I'm seeing there as opposed to just pure bone-on-bone rubbing, that you would miss that spatial resolution with an MRI. What I don't know is maybe you would gain information about bone edema or other things that would suggest that there is pathology there. So it would be great to have both, frankly. And we haven't really gotten into that a whole lot.
You can't do it, Mary Beth, sorry.
It'd be nice. Not happening.
Thank you, guys.